Before we dive into the agenda, just really quick about who we are and why do we get to talk about this topic. My name is Demi Radeva, and I'm the founder of Akros Advisory. And I am joined by Clem Foltz today. And Clem and I have had the pleasure of working with each other for a while now. And we are seeing a lot of common issues when it comes to our clients and their go-to-market strategy, and especially in their process of selling to managed care organizations. By virtue of background, I have spent over 15 years working within managed care organizations and specifically focusing on buying digital health tech solutions. And so I'm intimately familiar with the process of how do you sell a solution to a payer and what it takes to purchase and make that decision. And then Clem, can you share a bit about you?
Yeah, so thanks, Demi. I'm Clem Foltz. I'm an actuary by background and training. Spent some time working in the healthcare space and really working on the payer side and understanding, kind of what the pressures are for a payer from kind of a financial actuarial view, and then have since switched and spent the last couple of years of my career working with emerging kind of solutions, new digital tech, things that are coming, kind of innovative solutions coming to market to kind of impact healthcare costs and supporting that go-to-market approach, but also trying to understand like how much value is there in these solutions from like a medical cost savings. And so, yeah, happy to be here.
Awesome.
Thanks, Demi.
Yes. So we partnered because we figured it might be best to just pull together a narrative around what we're seeing across the board. And so the objectives for today are really to help you understand how and why payer deals are won and what do payers actually buy. And alongside that, too, how do you build a believable and effective ROI story? Because we're seeing over and over again issues with startups trying to articulate their value and not really doing it justice. And then also recognizing how payers are built and the fact that they're different products, the different lines of business that they have, you may need to tailor the value conversation and the value narrative according to that line of business that you're selling to. And then from there, really helping you figure out how to make your go-to-market sharper by honing in the right population, the right buyer, and the right pricing for your solution. And then overall, we always try to make these workshops very practical and give you reusable tools or show you patterns that then you can recognize and incorporate into your processes. So with that, really the big problem that we see is that founders often emphasize clinical outcomes, but payers buy not just for clinical outcomes. They buy on revenue, they buy on the impact to medical cost, they buy on impact to administrative burden, also whether or not the solution is aligning with actuarial expectations, and the credibility and trust in the assumptions that you're making. And I think Clem can really comment maybe on the alignment piece and then the credibility and trust and assumptions piece.
Yeah,
And again, we'll expand on each of these as we go through the presentation. Go ahead.
yeah. From my perspective, it's really interesting because at the end of the day, basically every solution, if you're selling to a payer, it's going to go through some sort of business case, financial case review. So, and at that point, the rubber is going to meet the road of how is this going to be, how are we going to price this as it fits into our portfolio of products? And that, to me, that's where you want to set yourself up to be as successful as possible when you get to those types of meetings. I've seen situations where you've got really great clinical support, but then it falls apart when it actually hits the financial assumptions. And so you kind of have to work your way through, usually these payers are complex organizations and you're working with different departments and things like that. But it's really important to not neglect that financial component, even if you have fantastic clinical pieces.
So I think one of the main things around the financial component, just to double click what you're saying,
Mm-hmm.
Clem, is ROI, we're often seeing kind of the wrong way of approaching it. It's not just a calculation, but the calculation itself could be wrong as well. For the most part, people can now figure out how to navigate and create the ROI calculation, but then there's a bunch of other issues, including what I often see, which is founders citing external studies and basically saying like, look, so-and-so university did this study and it says that we should have an ROI of X, and so that's our ROI, which is absolutely not true or appropriate. And it can discredit you in a conversation with a managed care organization. We want to avoid that and prevent that. And then same thing with TAM, SAM, SUM. A lot of times I see actually the wrong calculation being used. TAM, SAM, SUM is not just you citing a market study of how big a market is. It should use your actual pricing model in order for you to get to a TAM, SAM, SUM. And so there is only one correct way to calculate ROI, and there's only one correct way to calculate TAM, SAM, SUM. So that's one thing, you know, just making sure that you're using the right calculation. But then two, understanding that all of these formulas are like proxies. They're also contextual, they're dynamic, they're assumption based, and those assumptions can change. So it's ROI is not static, TAM, SAM, SUM is not static. The moment you have a learning as you're iterating on the different hypotheses that you're testing in your go-to-market, those numbers can change. And so just being able to stay on top of it and stay aware, and then making sure that you reflect that across all your materials is really important. Clem, any
Yeah,
thoughts on this?
definitely. So like one of the things that I think about here, like everything you said is spot on. And to add on to it, it's like the ROI, and we'll kind of get into this a little more. It's like this is your opportunity to show what you know about your product and also their organization. And so if you cite a study on Medicare and you go in and try and sell to the Medicaid side of the business, it, sometimes that's enough to lose the credibility to kind of derail a sale. And so it's okay to not, like, these are insurance businesses that are taking risk and building assumptions. And so really you're trying to make this business case that's aligning with the right set of assumptions. And so you can make assumptions and say, well, I have this Medicare study, here's how I think it would translate to a Medicaid population. You know, that makes you sound more in line with the way that they're thinking about this, as opposed to, you know, coming in with, looking incredible or not quite understanding how your product is going to fit into the ecosystem that they have. And so I really think that, like, that ROI, having it misunderstood or miscalculated is also really important from a perspective of, like, you really want to make sure that you don't trip up. And, like, I've seen where you can get too complicated, and really the key is that you're trying to show your strength here. And even if that means you have to keep it simpler, everyone at these insurance companies is very busy. They're busy people. They're busy with a lot of different things in their personal life and work life. And so you want to give them an ROI that you're serving up in a way that's, digestible for a wide range of audience. And so I think that's another thing that I would emphasize here.
Yeah. So what goes into ROI, and maybe Clem, you can walk us through what is ROI made up of, and what are the key assumptions there?
Yeah. So when we were putting this slide together, I think that's sometimes people come to you and say, hey, I need help calculating my ROI. And I think the real question is, like, the ROI is built up of kind of a foundational piece to how you've structured your business. And so, really kind of being able to say, well, which components do you think you're struggling, the most with? Or, hey, if we do just need to calculate an ROI, sometimes the calculation itself is actually the least interesting part of the ROI. And it's really more about, well, which parts of your product do you want to emphasize, or where do you think the value as part of your story comes together? And then if you're thinking about your value proposition, I tend to think about it as like circles, where it's like you can have a large range of value that you want to claim, and then you're going to have a narrower circle that's like what you're going to try and prove in a financial calculation. And so you have to decide, like, what things are worth including in that calculation, what things can easily be calculated, but also, like, are there changes we can make to the other parts of the intervention and who we're targeting, like what population we're going after. That can change your ROI. If you're targeting people with $10,000 in medical spend versus $50,000 in medical spend, well, there's differences in the amount of avoidable medical costs associated in those populations. And that would then flow into how you price it, which then flows into your ROI and the value that you're delivering.
That's probably my biggest takeaway as I look at ROI, and as I work with founders, in the founder perspective, is the calculation itself, it's not that complicated, but going through it is going to help you hone in, well, who should I be focusing on? What should my pricing structure be? How should I design my product as a result of the insights that I'm getting from the ROI? So it forces some really helpful conversations in helping you really design your product and figure out your go-to-market strategy. And that's where I see the real value being of ROI. And then on the buyer side, having an ROI does help us compare apples to apples, different potential investments, right? So if I have a
Mm-hmm.
bucket of, a couple million to spend on different vendors, I want to spend and direct that money in the most efficient, effective way, so that 3 months, 6 months, a year from now, when my payer leadership asks me, like, show me your results, I can show the return on the investment that they made. So again, very helpful metric, both on the buyer and the seller side. There's another metric, though, that is widely misunderstood. And so we're going to get into that next. And hopefully, if you are selling to payers, managed care organizations, you are familiar or getting familiar with medical loss ratio. What is medical loss ratio? It's the share of health plans dollars that go to paying for medical care versus administrative or other type of activities that the health plan has to spend money on. And so MLR can be set by the government, as in where it's like regulated and you have to meet certain thresholds. And, again, in some countries, like in the US, we have certain thresholds that are set for MLR for a variety of purposes, including wanting to manage the profit pools for certain for-profit organizations, etc. But this metric has important implications when it comes to founders that are selling into health plans, because it also limits potentially the pool of money that they may have access to. So from a health plan perspective, this dictates how much money I can direct to changing clinical care versus changing administrative processes in my health plan. And so therefore, it informs how much money I can reinvest in those buckets. And beyond that, MLR is tied to executive jobs and compensation, shareholder value, contract renewals as well. And I'm curious, Clem, to hear from your perspective, where do you think the dollars are, and how should a founder think about medical loss ratio?
Yeah, it's a great question. And I think the MLR is really where a business, like for these insurance companies, this is where the whole business comes together in one metric, right? You're capturing how good did we do on a pricing of the risks that we're taking, and how good are we doing of managing the risks that we're taking. How all those components are built into what your MLR ends up shaping out to be. And so it really is like the one metric that brings you the closest to how the insurance company is performing and towards their strategy. And so for founders, I think the idea is that, like, where in the MLR, where are you coming out of from an expense component, I think is one of the additional, Demi, you and I talk about this quite a bit. It's like, if you're looking at it, 85, we'll see on some slides later, but like 80 to 90% of medical spend is going to be on medical costs. So if you can be if your solution comes out of the medical cost bucket, you have a very different sales process than if it comes out of the admin bucket. Admin usually only makes up a couple percentage of the overall premium dollars. And
And the
so,
majority of solutions today, especially from a digital health tech perspective, are coming out of the admin budget. And so, but there are ways, and we have done this for clients, where we've been able to reposition their product in a way that it comes out of the clinical bucket. And I have one quick example that's coming to mind, is around nutrition and nutrition benefits and like meal delivery, of like shifting that to clinically tailored meals, and then all of a sudden you're coming out of a different bucket of spend. than administrative costs or foundation dollars, or other funding methods.
Yeah. And I think that just highlights like these are the things that the payers care about, and this is what your customers are caring about if you're selling to them. So you really want to do the best to frame your value proposition, from a financial perspective around these MLR levers. So around increasing revenue, lowering admin cost, or lowering medical costs. That's really the business boiled down to the less human side of the healthcare side, but it's really that's what it boils down to at the lowest level.
And a couple of things to note about MLR, is that MLR fluctuates, it changes. Again, there's all types of context. It shifts with utilization, it shifts with the enrollment mix of the payer, it shifts with macro trends like a pandemic. And so here you can see some of the biggest payers, and their MLR is different. And that gives different signals. So Clem, when you look at this data, what does this signal to you in terms of product mix for payers or other things?
Yeah, I think I was mentioning to you, like it shows kind of different strategies that they're taking. So you can see, like, I think the difference between Centene and Cigna there, it looks like Centene's probably either having some tough quarters, or they're targeting members who have a lower, they're targeting a different cohort of members and profile. So they might have more government programs. Whereas Cigna, they're probably more on the commercial side of the business. You usually have a little more flexibility on your ability to kind of tailor the price. We'll talk about that a little bit more on the commercial side of the business, as opposed to, you're usually the insurance company, these MCOs they're more taking the price available to them or bidding on it for the government programs.
And typically a higher MLR means you have a more complex population to manage. There's more clinical spend versus the lower ratio, the
Yeah.
healthier potentially population and the less spend.
Yeah, and I think that's directionally right, Demi, but I think I also encourage
It's more
people to think about,
complicated than that.
yeah, because like the revenue is really important too, because like that's what you're dividing it by, or about the revenue. And so it's like, your revenue 10 years ago, even though your MLR might be the same on a percentage basis, you might be looking at a very different structured type of business. And so, and you might have also just mispriced risk or taken a contract that you knew wasn't going to perform the way you thought it was, and that can be part of your strategy and push up MLR. So, but yes, it is typically associated with more complicated. If you priced it right, then you're associating it with more complicated medical people,
Mhm.
patients,
And there
members.
could be real significant implications to the business. If you are out of bounds of the regulation around MLR, you may need to actually be required to pay rebates, um, and other things that have actual implications to your business, as a payer. The other thing, we wanted to note and show you all is that MLR can vary, by timeline. So you can see here, for one payer, so Aetna Health of California, 2019, 2020, 2020, 2021, their MLR for their ACA population went from 49% to 44 to 72. So you can have that variation from year to year to year. And then you also can have variation of MLR across the different products. So these are the commercial products, ACA, and then small group and large group. So you can see differences, again, in the MLR across those products. And here's
Yeah, I think
another example. This is United Healthcare, in Florida as well. Go ahead, Clem.
Oh, I was just going to say, yeah, I think that's what's really interesting is that very different business, like even within the same payer, you're going to have very different MLRs by line of business. And I think, yeah, that was my main comment. And we'll talk a little bit more about what drives that in a second.
And I was going to say, if we've just about lost you because you're like, what are we talking about? Why are we talking about MLR? Why are we talking about, ROI? How do you calculate? We thought you're going to teach us how to calculate ROI and MLR, which those are widely published. I would highly encourage you to, research online how to do those calculations, or reach out to us afterwards, and we're happy to share some materials with you around how to do that. But here's where it all comes together. So maybe Clem, walk us through why do we care about ROI, MLR, and how this all ties into how you actually sell to a payer.
Yeah. And when you think about, I mean, what you're doing there is you're trying to sell to the payer and understanding the position that they're in. just puts you in a better position to position your product and why they need it. And so understanding the pressures and kind of the framework for how they might be evaluating you, and understanding, you know, is your solution going to be top of mind because they have a problem with that specific condition, or that whatever you're trying to solve, where does that rank in terms of their priorities? And their priorities are going to shuffle around based on their MLR and the pressures that their business are under. And then we've just started to like summarize, like one of the things that I often see as a common mistake, and I kind of had mentioned this at the beginning, it's like, you really want to be clear about which line of business that you're trying to sell to. And like, to me, it's a red flag for a solution to think that they have the same ROI for each line of business, because each line of business has very different characteristics and experiences. And so here we've laid out 5 lines of business and showing like Medicare Advantage is usually, these are older people. These are typically people over the age of 65. And this population is a higher utilizer of services. The prices are usually a little bit more controlled because it's through government, the government programs. And so the unit cost isn't as high, but the utilization is high. And so that's a very different ROI. If you think your solution is going to, like, I'm just going to make something up here, but if you have some solution that's going to save inpatient hospital stays, which are, a really expensive thing for a payer, well, the cost of that stay is very different for each of these lines of business, or has the potential to be very different for each line of business. And also, what the likelihood of someone ending up in the hospital also varies by each line of business, and you want to be able to inform that in a digestible way for the audience for your line of business. And so I don't know if I need to go deeper there, but Demi, I'm curious if you have any other thoughts on this slide and how I'm laying it out.
Yeah, I think the biggest thing to understand here is populations vary, and then also the reimbursement rates and our unit prices are going to vary as well by line of business and population. And so you really want to figure out where do you fit in, and this is what founders that work with us really love, is we can help them figure out where they can maximize their profitability as they're going to market. And that can be critical. It can make or break your business. You can spend years trying to go to market in the wrong state, or with the wrong ICP, and with the wrong pricing model. And so it's really important to be able to look at the information holistically to hone in, okay, I should go to market in Texas, and I should go to market with commercial payers, not Medicaid payers. And specifically within commercial, I should focus on ASO or fully insured, and here's why. So this,
And
yeah,
this
go
this
ahead.
can be such a daunting, I think it's going to be a little daunting to try and like digest all of this. I guess I'll offer one piece of hope or feedback here, which is that like the payers don't often expect you to know the intricacies of their specific line of business, but where you can really get tripped up is that if you don't make the right framework for how you're structuring it. So like they're just trying to make a sound business decision. They won't expect you to know exactly the unit cost of a hospital stay in their specific line of business in their specific state, but you want to be able to make sure that you're educated enough that you're not going to pretend that it's the same unit cost across these lines of businesses. That's where you'd start to lose your credibility if they're, oh, well, we're thinking of using you on this solution, and you're like, oh yeah, well, it's the same ROI if we jump to this other one. You really want to be able to just talk through at a high level the differences. And then where I see payers often come in is they can fill the gap. They have the data, they know how to price this, but you want to make sure you're giving them the right framework for how to think about this.
Yeah. Here's a little bit more detail too that I love, but with each one of these lines of business, there comes a different pricing calendar. There's also a different risk appetite. And so when I think about ASO contracts and line of business, they have a very high risk appetite. They will try anything to attract talent, or retain talent, or increase productivity. And then also from a health plan perspective, I will try as a payer to please my ASO contracts as much as I can. And so I'm willing to go out of my way to partner with whatever cool new digital health tech solution is out there. And what I'm seeing a lot in the marketplace is these libraries or platforms that are like plug and play that these payers would curate and pre-approve so that any employer that's in an ASO contract with them can sort of say, okay, I want these 5 digital solutions turned on for my employee population. So there's a lot of interest and demand for kind of risky, cool, shiny tools to attract and maintain talent there. But then when we go to some of the other populations, that dynamic changes.
Yeah, and again, this is to me what you just highlighted there, Demi, is it's about making sure that you kind of know the pressures and the context for each of the lines of businesses that you're potentially targeting, and they each have different, we'll talk about this too, but it's like the different levers available and what their risk appetite. I think of like a fully insured business. Those business leaders are often potentially have their jobs on the line if they don't meet the MLR that they're trying to hit. And so they might be they tend to put more scrutiny on the products as opposed to, if they're a pass through and they're just helping a self-insured employer, the employer might say, yeah, I want this to be a successful, program or intervention, but I have a little bit higher tolerance for if it's not exactly what's promised to me. And so, that kind of varies even on the Medicare Advantage and the Medicaid. The ultimate payer is the government and the state. And so, if you can fit into the way that they're operating, they might be willing to pay for you, even if it's not like the greatest ROI, because they're trying to take advantage of different opportunities within those programs. And so it really just, we just laid out here some of the things that it varies by.
And I think to bring it all home, what Clem and I were discussing ahead of this, as we were prepping for this workshop today, was that medical cost savings and differentiation are really the key criteria that's driving purchasing of digital health tech solutions across all of these lines of business. If you're a Medicaid MCO and you're trying to win net new business in a new state, you want to have different solutions to present to the state that will help articulate how you're going above and beyond and why, if you're Aetna or Molina, you should win that contract versus, a United or another health plan. And so I've seen, especially within Medicaid, this, they have whole workforces that are stood up before a renewal cycle so that the health plan can prep and think about what is our strategy for population management for a given state and what are the digital solutions we're going to be including in our pitch. And so that's where you can land contracts really, really quickly. There are some things to watch out for, though, is they might want to lock you into an exclusivity contract, which if it's your first payer client, it's kind of, it's a blessing and a curse because, okay, great, you can show traction, you lock in a client, but then if you're locked in for 3 years, your investors might not be as happy because then you can't lock in other deals unless you go outside of that state into other geographies. So there's a lot of little things that need to be thought through. Curious, Clem, on any comments you wanted to make on
Yeah,
the
I really think
Mhm.
that's a helpful, like, to me, what you're talking about is like the strategic reasons for why you might buy one of these products.
Yes.
There almost always ends up being a final gate or a gate somewhere in there that revolves around, like, I hear a lot of like finance leaders or medical economics people who are basically just like, well, if even if there's a great strategic reason, we want to make sure that this program at least pays for itself. And so we want to make sure that we're making conservative enough assumptions and that we understand how it's going to impact. Because one of the things these payers are often afraid of is that new solutions might drive up healthcare costs and make them less competitive, or, like, healthcare costs, as we all know, are already increasing at such high rates. And so we're trying to make sure there's a lot of process in place to make sure that, we're trying to do things that don't just add extra cost to the system, but instead, have the ability to try and lower cost over time.
And going back to our earlier point around ROI being contextual, there's multiple things that can affect your ROI calculation, including what line of business are you focused on? Is it Medicare, Medicaid, commercial, and which commercial? Who is the target population that you're targeting? What is the spend type that the money to pay for your solution is going to come from? Is it, again, clinical or admin? And that's where MLR can give some indication. And and then there are others around pricing window and time frame to produce return on investment. It's the risk model, implementation friction, and other pieces.
Yeah, Demi,
Clem, do you have a comment?
well, I was just going to briefly say, I think because we probably should, because I think both you and I, we've had so many conversations about this. We could talk for a long time about the kind of
Mm-hmm.
the intricacies, and it's really interesting to see the variations between payers, and like the level of scrutiny varies based on, how mature of a solution you have. It's quite a range of things that are out there. So I think we could probably, with that, maybe move on to the next slide. But I feel like we could talk about that for a long time, maybe another time.
So if I had a penny for every time a founder asked me or came to me and said, but what if we give our solution for free? Why won't they just take it? And a couple of thoughts to that, but one, free is never free, right? There are implementation costs on the health plan side that are going to be required to turn on whatever solution, regardless of how unsophisticated, or maybe you have a solution that requires minimal to no implementation on the health plan side. There's still going to be things that need to be put in place. And I just think about even Medicaid marketing. There's so much regulation about like what can you actually advertise to Medicaid members and not advertise, and how do you sell it? How do you work through the health plan's operations to get your solution in front of the potential users of it, right? And that's also a big failure point for startups is and as health plans have moved away from just pure PMPM models to PEMPM models, meaning instead of per member per month, it's per engaged member per month. So you have to, one, as a startup, figure out how you're going to get the users to get your solution and download it, and then you're going to have to figure out how to like keep them engaged and keep them using it for the program to work and for there to be any ROI in the first place. Any thoughts, Clem?
Yeah, I was gonna say one quick thing I'd heard is like I actually had a payer say this to on a sales call that I was on, but they said just the cost for us to contract can be several hundred thousands of dollars because it has to go to our outside legal. That lawyers get expensive. We've already allocated so many internal resources to these projects that like just to actually put a contract in place can sometimes cost hundreds of thousands of dollars. And so, that's just something that they have to consider that has to be covered essentially by the cost of this program or solution.
Granted, a lot of that is changing now, and they're more and more simplified processes. We do have a podcast available on our Spotify where at Health, I interviewed leadership at UPMC, and they're completely changing their procurement process to help
Mm.
to alleviate that friction when it comes to integrating digital solutions. So if you're interested in that, I highly urge you to go check that podcast out. Um, but again, free is not free. And then the other thing too is um, free doesn't, there needs to be a stake in the game. You need to be able to show that there is actual demand, that there are customers that are willing to pay for your solution. And so free actually costs you a lot as a founder to kind of get started and make the point that there's actually a need for the solution that you're building out there. And there's a lot of great solutions out there that just don't have a buyer. And so it's better to find that out earlier than later in the process after you spend millions of dollars building a tool that nobody wants to actually pay for.
The value isn't there.
Mm-hmm. So again, just a few pieces. Integration, again, you can solve for that integration problem by having something very easy to implement, but then there's also legal, operational cost, and also opportunity cost. Again, typically payers, when they're looking at your solution, they're not looking at it in isolation. They're actually comparing across multiple business cases and multiple different solutions, not just within your category. So let's say you have a solution that's in diabetes. They have a budget that may be allocated across multiple conditions, across multiple populations. And so oftentimes you're not even competing within the same category of dollars. Great. So what do payers actually buy? In my experience, and again, I've been doing this for many years, and I was very, very deeply involved within United Healthcare's TechStars program and the accelerator program that they had. And the whole goal there was to figure out how do we streamline and how do we partner with disruptive solutions so that we can grow the business. And so the solutions that I saw most successful was they were solving a very clear problem. And with a very clear problem comes a very easily quantifiable value. And so to make it a clear problem, that also means that you have a very specific population that you're targeting. And then from there, the operational lift and all these other components kind of become like, we just need to make it happen because the problem is so clear and the value and the benefit is so clear. I'm curious, Clem, what you've seen in your experience.
Yeah, I think from where I'm usually involved is, hey, we already think this solution is good. There's already an internal champion from a clinical perspective. Clinical has basically said this is good. We want this. And now, how do we actually make sure that we are aligning the assumptions from a financial perspective to make sure it's covering the cost of the program or whatever the threshold is? And and from my perspective on that, it becomes, if you're targeting a more expensive population, there's usually more opportunity to avoid unnecessary cost. And so it's kind of this puzzle of like figuring out, exactly what's the right level of credible assumptions that can get us through and the right framework with the payers to be able to get approval on that.
I think like with any health technology assessment, there's two pieces to it. There's the clinical effectiveness and then there's the cost effectiveness. And the clinical effectiveness is pretty clear. Payers, for the most part, know like what is the prevalence and what is the incidence of various conditions in their populations. They know if diabetes, hypertension, stillbirths, whatever is a key problem within the respective line of business. And then from there, it's the cost, it's the ROI, it's the financials that need to come together to make a solution make sense. Okay, so now we wanted to spend the remainder of the discussion on a variety of case studies of actual clients that we've worked with, both independently and then together. But I did want to pause and see if there's any questions.
Looks like we had one in the chat.
Yeah, let's see. Okay. Could you provide some more examples of how to position an offering for MLR versus administrative? Like the earlier one of meal delivery repositioned as clinically tailored meals. Yeah, Clem, I'm curious if you had some examples on that as well.
Yeah, I would say, just by nature of like my background, I usually get more involved with organizations that have already like want to be committed to the clinical side of the equation. So, I'm often trying to help a solution frame itself in terms of inpatient visits, ER reduction, things like that. And so, what solutions can fit into that framework? Well, I'm working with an SDOH kind of company right now where it's like they have nothing to do essentially with medical cost if you were to like think about it, but at the same time they do, because they think that like if you solve this SDOH factor, then that should reduce your healthcare cost. And so we're positioning them that way. To me, it kind of comes down to, is there a credible link between whatever you're doing in medical cost, through published studies or through your experience, or can we put together a credible proof exercise, their ROI, and then B, yeah, I guess I didn't know what my B was. I kept talking and got excited.
It's okay. Well,
It'll come back to me in a second, I'm sure.
well, it's funny because the social determinants of health is a space that's like super near and dear to my heart, and I've actually been a founder in the space. And one of the biggest things that we do today is actually work with nonprofits and help them quantify the value of their social care services and articulate it in a way that it makes sense for a managed care organization or a provider organization to make sense of the value of a fall prevention class in the context of their population and how many ER admissions they're preventing because their senior population took a fall prevention class, or how many diabetics are not ending up in the ER because now they have access to stable food because they get to go to the food shelf and get meal delivery. So SDOH is a big one where we quantify a service that's traditionally defined as social care, and then contextualize it and make it fit the framework of clinical care in the US. And so it's interesting because I did spend a lot of time working internationally while I was at Optum, and then also as part of my master's. And in a lot of other health systems, social care and healthcare are one. And in the US, we have this two systems operating very much separately. And over the last 7 to 10 years, I've really seen that merging start to happen. And the only way that's happened is through the articulation, the calculation of value, and really being able to make the business case.
And I think it comes down to like many things can be tied back to medical cost if that's the way that you want to frame it. And so, it really can be, that just has to be the goal from the beginning. And it's a different set of bucket of expense. Like most payers are more eager to engage with a solution that comes out of the medical cost than they are on the admin side, which I think we'd already touched on there.
Great. Do we have any more questions? Does anyone want to unmute and go for it? I see another one in the chat here about types of marketing communications that could be considered for quality activities. And I think, Kimball, it's best if I take that offline with you. So I'm happy to chat more about that. Okay,
Thank you.
Clem, I think we should get into the case
hit a few of
studies.
these case studies. Yeah. So this first one I had here, and I'll just kind of high level talk through it, is there was a solution. It was actually by like a serial entrepreneur, and during one of their previous startups, they had found a problem that they thought should be solved. And so then they went and built another company to solve that problem. And as part of that, it had this like almost incredible value, which was they tried to prevent inpatient and ER visits at the moment they were occurring. So like they would try and prevent them, and you basically would only charge the payer if you basically eliminated those visits. And so it was almost so good that like they were struggling at times during their sales presentations because A, they were struggling with how to communicate it, and B, it was like the payers almost didn't have a way of going into their claims warehouse and verifying some of the claims. But at the same time, like it was very clear that that was actually more of a limitation on the data than it was actually a reality on the ground. And so we really worked with them to reframe their solution in terms of like a way that a payer could understand it, and really try and use the language, the utilization, the unit cost, instead of trying to make payers work and try and understand a whole new framework for thinking about these type of problems, work within the framework that the payers are already using, which tends to be unit cost and utilization. And then from there, that actually, this solution, the revenue officer called me after we'd had this conversation, and then he was talking to a payer, and he brought up, they basically were like at this, he was in with the payer, and the conversation wasn't going great, and he decided to just, as a long shot, hey, could we talk about this in terms of unit cost and utilization? And he's like, it was like a light switch flip. The payer was able to rattle off, because these payers have like, I call them like walking around numbers. Like they often know what their utilizations are for specific lines of business. They often know what their unit costs are. And if you can frame your solution in terms of that, then you can really quickly get someone in, bought into understanding how you're generating value and the value of it. And so that was a really fun one for me, because it was like, someone calling you excited because they felt like a deal moved forward just by changing the way that they were communicating. It wasn't changing anything about the product, just making sure that you talked about it in a way that related to the buyer.
This is probably like the biggest takeaway from today is you should really get intimately familiar with the customer that you're trying to sell to and how they
Mhm.
speak about things, what resonates with them. And so this is just another example of we had we have a client that has such a high ROI of like 15 to 1, which is like completely unheard of. And so like the main objective is like, well, how is this possible? Like this is not true. You must be like lying in some kind of way. So then we worked with them to really reframe the numbers and focus things on dollars saved per member per event, and really articulate things in a different way to where we've been able to kind of move beyond that objective now of like, this is unbelievable, to, oh my gosh, this is incredible, we want to partner with you, let's have that conversation. And then yeah, Clem, talk about
Yeah.
complex ROI.
So
This is very common, actually. We see a lot of
yeah.
folks come to us with like 500 line items that feed into an ROI number.
Yep.
And so this is a big one.
And
Go
so
for
yeah,
it.
so this one's interesting because I actually sometimes this happens with clients where they've actually built their own ROI spreadsheet, and it's usually not bad. Like it's actually usually pretty good. The problem is, remember, your audience is people who are getting pitched 500 of these solutions every year. And so they're trying to navigate this quickly, and they're also trying to run their own businesses at the same time. And so you can really burn yourself by making, an overly complex ROI, or just an ROI story that sounds too good to be true. So in this specific example, there was a vendor that I was working with who, again, I think their ROI was quite good, but they had like 9 categories of savings, and it was like progressively getting smaller. So by the end of it, it's like the first 3 categories of savings, made up 85% of the savings, but then they're basically throwing everything in the kitchen sink in to try and get to a little bit higher ROI. And my point was, yeah, but then all of a sudden it hurts your credibility and it seems almost unrealistic. Like no one's going to measure the 9th thing that you're telling them for, an extra couple $1,000s of ROI. And so we really worked with them to streamline it to a tighter story where it was really built around like 4 core drivers of ROI. And then we actually added in, because this is actually pretty common, I feel like with a lot of, especially medical solutions, is you actually expect costs to go up during the program. And I've seen some solutions try to, either hide that or just they shy away from it. Whereas like depending on the solution and, how you're positioning it, I often try to lean into that and say, hey, we have an assumption in here that says we think these types of claims are going to go up. We think there's going to be more preventative care that happens, and we're going to save even more on, that's how we're earning the inpatient ED reductions. And sometimes that buys you more goodwill with the payers to say that you're actually approaching this from a more realistic perspective instead of saving. You're saving everywhere, which is probably not quite true. We're going to kind of own up to some increases in cost in a few spots and then, pay for that with bigger reductions in other spots.
If you're solving for everything, you're really solving for anything, right? But I think the other big component is, and we do have a workshop on this, is um, the ROI component. The biggest issue with this is attribution, and this is
Yeah.
why payers also have moved from PMPM to PEMPM, models as well, is because they need to figure out, well, out of the 15 digital health tech solutions that this member is using, how do we know that it's your specific solution that helped prevent them from going into the ER versus these 15 other ones that they have access to? And so attribution is a really big problem. And again, if you have a list of 15 things, is that truly the case? Oftentimes payers will immediately say, like, come back to you. And we just had this happen with the client, is we typically prep them and we ask for all of the possible KPIs and all of the possible claims data that we can have access to, so that we can articulate and maximize the value back to the payer, and then the payer came back and said, we're going to give you just 2 of these. Like that's all you get. Everything else you can't claim that you're generating savings, even though there may be some tangential, savings that are generated by virtue of the solution. They're just not going to allow that. So
it makes their world too complicated to try and calculate out who's claiming which savings, because I think as part of that complex piece, you often see, everyone's claiming so much savings that that you add it all up. I think a classic example is, you're a payer and you have 7 solutions that are each going to save you 10% of your medical costs. Well, my medical cost should be, disappearing, but instead it's still going up. And it's like, how do you untangle that mess? And one thing I would add on that complex piece is, like, yes, people are busy and, these sort of things, but, I think what your experience there, Demi, was actually really unique, because I actually see a lot of payers they're really polite. And so they won't actually even tell you that, like if you pitch too much.
This was after the contract was signed.
After the contract was signed.
Yes, yes,
Okay.
yes.
So that's a
Once
great
they
example.
signed the contract, there's not as polite.
Because I've seen that, like, yeah, once they sign the contract, but like, and I don't even know if it's necessarily polite, but like from a payer's perspective, there's not a lot of good that can come out of like totally bashing a solution. So they tend to be like, the meetings tend to be warm-ish, and like, or they'll send you on wild goose chases to prove more evidence or things like that. But like, I've found that there's a lot of solutions where they have these meetings with payers and they go, okay, but like there's no like path forward. And so sometimes that's a sign that, someone calls you and they're like really excited. Like, I had a pretty decent meeting with a payer. And to me, it's like a pretty decent meeting might mean that you had, something that was too complicated, or you had something that they didn't quite believe, or you lost some credibility, and there wasn't any benefit for them to outright tell you that. So instead they just were kind of polite, and then the sale kind of fizzled out after that. So
Yeah. I'm just watching the clock. I want to make sure. I know we have a few more case studies, but I think, Clem, maybe we can cover this one, and then folks that want to follow up with us we can provide more information. But yeah, why don't you walk us through this one, and then we'll wrap it up.
I'll hit on this one relatively quick. I think it's just a different variation of what we've been talking about, which is here the client that I was working with had like a pretty premium price product, and they came to me saying that they wanted to sell it to everyone within a certain category of cost. And it's like, well, from a payer's perspective, that's, raising flags that I'm going to be spending way more. Like, my members in this category are not costing me as much as your product is. And and so the idea of like inducing a bunch of utilization, I get worried that that's going to raise my prices. And so instead, what I pitched to them was, you couldn't handle the influx of managing that many members with a big payer anyway. So why don't you tell the payer that you'll screen the members for them and feed that information back to them, and then you'll only enroll the high risk members who are more likely to generate an ROI for your product. And that went over extremely well. The payers responded by saying, this person called me after the call and was like, the payer loved that. They felt like I really understood them, and they felt like they've tried to pitch that back to vendors sometimes, and they just were really pleased with it. And so that revised approach just really helped kind of move the conversation forward with those payers.
Speaking of different ICPs, we do have a case study where part of the process of what we do at Akros is really help our clients identify who the right ICP is through iterative testing. And so you can say, oh, I should be focused on, TPAs, or I should be focusing on MGUs, or I should be focusing on, you can have an initial hypothesis, but then until you get out in the market and you really start having these conversations and you have cold or warm intros into these organizations, that's when you truly get to understand what are the objectives, who are the main personas that are buying a solution like yours, and how much are they willing to pay, and what is the way to structure really your product. And so in this particular case, we actually use claims data to validate the different the different clinician types that were driving utilization of our client solution, which was critical to drive device adoption. This is for a med tech company. We work both with health tech and med tech companies. And so it was, fascinating. Before the work that we did together, our client was focusing and going after orthopedic surgeons. And after the work that we did together, they realized that physical therapists are really the ones that are going to drive adoption to their solution. And so we do this across all types of clients, is really help you hone in, like, who is the clinical type, who's the right ICP, is it national MCOs, regional MCOs, local MCOs, and why, right? What are those key pain points that you're solving for? So we want to leave you with this one, takeaway, is that yes, you could have clinical results and they could open the door, but it's really the financial logic that's going to close the deal. And not only that, but how are you articulating that logic? And so being mindful of the narrative and really understanding your customer is going to be critical to this. And I think I can speak for Clem and I, like we pride ourselves in having been on the buyer side for so many years that we really truly understand what it takes to sell a solution to a payer and to close a deal. So we'd be happy to help any of you with your go-to-market strategy. And with that, feel free to reach out to us at Demi at Akros Advisory and Clem at Momentum Actuarial.